Sex Talk with the Siegel Brothers is a weekly program designed to answer all your questions, including the ones you didn't even know you had, and to clarify the endless debates around the wonderful and fascinating world of sexuality. Join us for real talk about sex from two experts in the field. Richard and Larry Siegel have over 50 years of experience as sex therapists, educators, counselors, and researchers. The Siegel Brothers are recognized around the world as trainers of medical and mental health professionals.
Hello and welcome to Sex Talk with the Siegel Brothers. I'm Dr. Richard Siegel, a certified sex therapist.
And I'm Larry Siegel, a clinical sexologist and certified sexuality educator.
And my awesome big brother.
That's my favorite role.
And thank you for joining us for this week's episode of Sex Talk with the Siegel Brothers.
Indeed.
What are we drinking
to you
with?
all. We have another unfiltered sake tonight.
Milky sake?
Milky
Nice,
sake.
Appropriate?
Yes, indeed.
Cheers to all of our viewers.
So I hope everybody is staying safe and well and at least having some good conversations about sex, if not having good sex.
Right. The silver lining in any crisis is making the best of it and trying to reconnect.
Indeed.
Especially when stress is increasing and tempers are shorter and...
Mm-hmm.
What do you mean by that?
That's right. You know, now is the time, really, with all of this sort of still staying at home, people still minimizing how much they're going out, to really focus on the relationship, especially those of you as families, as couples that are spending all this time together indoors. You can get on each other's nerves. I should rephrase that. You will get on each other's nerves, and that's not news to anybody. So it really becomes an effortful decision that we have to really be making and thinking about to stay focused on the relationship. Stay focused on trying to be as positive with each other as possible.
And that includes parent-child relationships?
Yes.
Those of you who are parents, as sexuality educators, we're obligated to always be vigilant for the teachable moments. And while you're trying to catch up to your kids' algebra and geometry and help them with their online schooling, why not take the opportunity once a week to have a little sex talk and do some sex ed as a family? Mm-hmm. What better way?
Right.
Hit us up on our Facebook page or YouTube if you'd like some recommendations on some wonderful books and resources for talking to your kids and how to raise sexually healthy kids.
Absolutely. And, just to add on that, because that's really a very important point. With all of the homeschooling and with people not being in school, it's been a problem even when kids have been in school that there's really no sex ed.
No.
But now at home, there truly is no sex ed.
So except this maybe for porn.
Well,
or,
that's, we've talked about that before, how porn has become the de facto sexuality educator for most kids. So here is really a good opportunity for parents to really use that time to talk to your kids, have these conversations, make it part of the work that they're doing with their other schoolwork as well. As you're looking and overseeing their work, as you're helping them do that, throw this in. This could be in addition to what they're already doing.
Imagine the looks on their faces if you give them worksheets or blank anatomy diagrams and say, here, fill this in.
That's right. Or let's talk about this.
Right.
So here's I can't imagine really in some ways a better opportunity to fill that void that schools have not been filling when it comes to sexuality education.
Well, there's a good segue. We typically start our show with a little look at some sex in the news. Mm-hmm. Tonight we're going to break tradition and ask a slightly different question. Why is this news?
Yeah.
So our rant for the evening is sexual medicine and why, in a nutshell, penis and vagina doctors are so woefully inadequate and untrained and ignorant about sexuality.
Mm-hmm. Right. And just to sort of translate that question for our viewers, we really have been talking about this for a long time, that OBGYNs, right, doctors who are really all about babies and vaginas, urologists who are all about genitals, really don't. And I like the qualifier there. Woefully unprepared and, dare I say, ignorant about sex and sexuality.
I mean, sexual medicine, thankfully, has always been around, but very small, kind of a fringy thing. Viagra's approval by the FDA in 1998 represented kind of a rebirth of sexual medicine, really for no other reason than urologists had something to say to guys who were complaining about what they used to call impotence.
Right.
Right, which if they were weren't so humiliated that they could even bring it up to ask their doctor, and urologists typically said, well, we all get older, and right, unless there are severe medical issues, severe diabetes, or those kind of complications, where they use shots, injections, and we know men don't want to hear the words penis and injection in the same sentence.
Right, exactly.
Right? But sexual medicine, yes, it's been growing rapidly, but there still has not been a sufficient integration of sex therapy, of the mental health, and the relational contexts for the sexual problems that people bring for no fault of theirs. Who else are they going to ask?
Exactly.
Women ask their gynecologists,
Exactly.
men ask their urologists.
Right. And you'll forgive me if I don't share some of that excitement about the advent of Viagra and Cialis, Levitra, as a boon in sexual medicine, because most doctors that were even prescribing that, you're right, it gave them another option, but it didn't get them talking anymore.
Right. Didn't get the questions asked.
Exactly. And it still very much negates, like what you just said, that relational aspect. Sex and sexuality require context. And whether that's the context of the way people relate to each other in a relationship, or the way an individual relates to themselves within the context of an intrapersonal relationship.
Right.
And we still, across the board, see so few medical professionals that are able and or willing to talk to their patients about these things.
Yeah, the able part is important because most doctors have about, 5 to 8 minutes in the exam room with each patient.
Right.
So it's always, we talk about that doorknob,
That's right, that doorknob confession.
The doctor's trying to get out of the exam room, and the patient goes, "Oh, doc, by the way, there's this thing, it's really embarrassing," and the doctor's like, "Get me out of here," right? Now, if the physician could say, "Hey, I'm glad you brought that up. We have a sex therapist that's here every Friday.
Exactly.
Why don't you see the girls on the way out and schedule an appointment?" Done.
Right.
The referral's made under the same roof if possible. Not to have to worry about the patient going to call another clinician in another place and schedule another appointment.
Right.
That's how it works.
Yeah, well, that's how it should
It's
work.
the dream team.
Exactly. Right? When we talk about that, we've talked about for a long time, calling it this integrative practice, bringing it all together. Because right now, it's sort of like, you want to eat a pie, but one piece you have to go over there to eat it. Another piece you have to see if it's around the corner over there. Another piece you want to go to another town to have it, and another one that you don't even know if they're there or not. And it's just so disjointed, and it's just the cohesion. Right. And again, it's a word I don't like to use because it's used so incorrectly so often, but it truly is one of the most holistic things we have when we talk about sex and sexuality. It encompasses every aspect of ourselves, so it makes sense that we're going to need a number of professionals to deal with all of those pieces that it entails. And we just don't have a whole lot of that out there.
Well, happily, there are a few. There's a handful, we're privileged to know a handful of people scattered around the country who are setting up these kind of one-stop shops. Some nurse practitioners are very well positioned. Again, gynecologists, physicians, and pelvic floor physical therapists. So when we come back, we have the pleasure of interviewing one such dream team member, integrated sexual wellness medical practitioner.
What we like to call a unicorn.
Indeed.
I'm Rachel Needle, co-director of Modern Sex Therapy Institutes. And Modern Sex Therapy Institutes is a continuing education provider. We provide continuing education for medical and mental health professionals around the world. And we have over 140 archived workshops on our website, so please check them out at www.modernsextherapyinstitutes.com. Also, we have a number of certification programs, including sex therapy, couples and sex therapy, LGBTQIA affirmative therapy, alternative relationships, transgender mental health care, medical sexology, sex education, and sex counselor certifications. In addition, we offer a PhD in clinical sexology. So please, again, go to our website, check out everything that we have to offer. A lot of our stuff is available solely online from the convenience of your own home or office. We do things live in 8 states and live via webinar as well.
So our guest this evening truly embodies what we were talking about, the integrated medical practice, the dream team. And she is a pelvic floor physical therapist at the University of Texas, Austin Health Center, program director of the pelvic health program there, Uchenna UC Ossai. And it's our pleasure to bring you this interview. So we are back, and as promised, we have a wonderful interview lined up. Well, we're very excited about it. We know it's going to be wonderful because I've already had the pleasure of meeting this wonderful lady. We're so pleased to welcome Uchenna Ossai, who is our guest, and as we said, a rare unicorn in this field, even in the sexology world, still a rare unicorn, a pelvic floor physical therapist, and a sex therapist. And as we were saying earlier, we've been banging this drum for as long as we've been at this, for the integration of sex therapy and sexual medicine, and slowly but surely, and nowadays, especially with folks like you, and I know we have a dear friend in common in Tracy Scher, and the newest forces in the dream team of sexual health and wellness. I want to just read briefly your intro, which I think is terrific. Dr. Uchenna Ossai is a sex-positive pelvic health physical therapist, sex educator, and counselor. Her sexual philosophy centers on pleasure and audacity. Right?
I love it.
While acknowledging the role that gender, race, and ethnicity and biology have on sexual development and expression. She spends her days treating people with both sexual and pelvic floor dysfunction, and her evenings educating the masses on everything that has to do with sexy time. Bravo.
That's great.
Welcome to Sex Talk. This is what we've been trying to do, and it's an honor.
It's an honor to be asked, and thank you so much for inviting me. I'm really excited to talk about sexy time and the pelvis and all of the things, everything in between.
Yeah, nice. My first question is why, even among physical therapists, after, according to my research, it was 1993 when it was officially recognized as a, pelvic floor physical therapy by the American PT
as a distinct modality
Association. And now, 2020, physical therapists don't know about this.
Yeah, no, actually, the section on women's health, it actually it's now the Academy of Public Health, but they started in the 70s, and it changed its name in the 90s, and then this year, they changed their name to the Academy of Public Health to include all persons, because everyone has a pelvis, everyone has a pelvic floor, and I think its roots were in obstetrics and gynecology that evolved.
Right.
But
we're in Eagles, right?
Yeah.
Right. Exactly.
Yeah.
Exactly. And so, for me, the only reason I became a physical therapist actually was to do pelvic health. And so, because my first exposure to physical therapy was working with a pelvic health physical therapist. And I was in high school at the time. And that's what got me really interested, because I thought physical therapists only worked with sports and elbows and backs or did neuro rehab. And so now, at that time, I told my parents, I said, I want to do pelvic health. I want to help people who can't control their bladder and their bowels and their sexual function. And my parents were like, great, okay. And so that carried through. But what I found through my training was that even though I had a very rigorous and excellent education, thank you, University of Illinois Chicago and Washington University, it wasn't, the sexual health component wasn't ingrained. Right. And particularly in the pelvic health training program. And I chose to do a residency program at Washington University in pelvic health. And they did a great job, but it was really difficult because I didn't really understand anything besides the physiology of erections. I didn't know how to address erectile dysfunction or premature ejaculation from a musculoskeletal perspective, nor did I know how to counsel patients. Mm-hmm. So it took me many years in my practice before I said, you know what, I need to get some didactic learning and figure this out so I can better serve my patients.
Right. And if I can, how much as part of your training, even in the pelvic health track, were they talking about sexual dysfunctions and disorders? And I imagine if they did, maybe sexual pain and dyspareunia and vaginismus in women, but I would imagine that would be about it, if that. Absolutely.
So they talked a lot. Again, I went to a really great residency program, and they talked a lot about sexual dysfunction from what we see in the clinic, right? So they'll say, dyspareunia, vaginismus, all of that, painful erections, things like that. But it was more focused in on the science of it versus the psychology behind it and what happened to the person, right, and how do we bridge them. And I think another thing that we didn't have, even though I was at Washington University, right, in St. Louis, where you have Masters and Johnson and all of that, I didn't really understand how to work with sex therapists. I didn't know that. I didn't understand how to partner with mental health in terms of helping my patient get better, because sometimes you have a patient who's there who wants to address it from a physical aspect, but sometimes that physical aspect can't be addressed until they get the mental health aspect handled. And oftentimes I would struggle.
Relational context.
Right. Mm-hmm. And I would struggle with my patients where I'm like, I really think you need to talk to somebody and get some mental health support first and get you grounded. And then you're going to get so much more out of the physical therapy. But I didn't know how to communicate that. I didn't know how to communicate that to my patient or to community mental health providers in the community. Wow. And so that's why I had to kind of step back, and I did the University of Michigan program. And that honestly was one of the biggest takeaways, was how to communicate with my colleagues.
Nice. Wow. We find ourselves, and over the past 30 years, just having to remind of physicians and a lot of PTs and just the sort of medical and healthcare professionals that when they're looking at these, like you said, they can understand it from the pathology, but not from the person perspective. And I'm glad to know that there's at least somebody we don't have to remind that there are people attached to these genitals.
Right.
Absolutely.
As we said earlier, they affect their lives and their relationships. Yeah. It started as a joke, but it's not, I guess, giving credit where it's due, medicine in general has gotten to the point where they can no longer not acknowledge sexuality as a quality of life issue. The cardiologists that used to say, oh, stop, I saved your life, don't worry about your erections. Or the gynecologist that said, oh, you need to drink, have a glass of wine. You just, right? Mm-hmm. They are kind of forced. So this is a drum we've been banging for a long time, this bridging of the medical and the mental health. But you did both, right? Because even in sexual medicine, clinicians are so woefully untrained in the sexuality, the mind, the relations, right? The relationships. So how did you take that physical therapy training?
Actually, what's funny is that I for undergraduates, or when I was in college, I did my degree in rehabilitative counseling. And
wow.
And so when I did that, I learned how to interview people. So that actually, helped me in terms of the physical therapy. And that's when I started to understand, okay, now I know how to interview people from this clinical aspect, but then how do I interview people from the sexual health aspect? Mm-hmm. And really, I think what most people are nervous about when they jump into this piece is, I I don't know, I don't want to offend, right? I don't want to offend. And understanding the principles, you know, of doing a SAR and having that structured support and education. So it was really a desire for me to just be better. I wasn't trying to get a certification because there weren't any PTs doing this at the time. You know, there are very few. I didn't have many mentors to reach out to. So kind of getting that understanding through learning that process, I was able to kind of say, oh, okay, so see this dilator therapy that I'm having this patient do, this might actually be traumatic for them.
Right.
So we may have to figure out a way to frame that, or I need to kind of communicate with their therapist, hey, I think we need to halt dilator therapy and really focus on on kind of getting that fear, that anticipatory fear under control, or maybe we can stage this a little bit better so that they can be more successful and they don't feel like they're traumatizing themselves.
Again, it's the dream team. It's the therapist working with the physician, with the nurse practitioners, with the physical therapists, the acupuncturists, the nutritionists. You know, this is another fantasy of ours, the one-stop shop sexual health and wellness center.
I hear you, and I'm very lucky in that I'm actually, you know, University of Texas, UT Health Austin. We do have a it's a women's health institute, but really we can see patients of all genders. But we have in the space, you know, OB-GYN, nurse practitioners, PAs. We have a licensed clinical social worker. We have a nutritionist.
Perfect.
So all of us are there. So
That's
if a patient comes in with like vulvodynia, they have the vulvar dermatologist there. They have the guy who specializes in vulvar disorders. They have myself. They have you know, our licensed clinical social worker who's also a sex therapist. So we all can sit down and talk together. And again, this is a unicorn scenario.
Yeah, we can just clone this whole center and plop it all over the country. But I want to read, this is more for Larry than for our audience, or as much for, what a horrible thing to say. But I know Larry's going to really appreciate this. Something else I pulled off your website, a quote: "Sex is like dancing. Some are born with natural crunk and rhythm, while others need a little more instruction. Clumsy or not, as long as you allow yourself to both enjoy and stay in the moment, you've mastered the art of dancing and sex." And I know that's great. I don't have to tell you that another exciting new movement in sex therapy. A lot of sex therapists. We've had a couple of wonderful lectures at modern sex therapy institutes, and a lot of sex therapists are turning to learn more about the so-called somatic sex therapies. So again, there you are at the bridge of helping people inhabit their bodies. And you know, I think there's a myth built up that mind, body, like they're different things, right? Like, first of all, there's no such thing as a mind. It's an idea to describe some things that our brain does. And if our brain is not part of our body, right? So speak to that, if you would.
Absolutely. You know, I think a lot of times when I talk with my patients and, you know, I bring up the biopsychosocial model, I bring up intersectionality, and they're like, well, why are you making it about, like, it's not a mental health issue? And I'm like, no. Mental health is physical health. Physical health is mental health. They're not separate entities. How you experience pain, pleasure, whatever sensation you have, that imprints on who you are as a person. And that is part of that's part of who you are. That's part of your psychological development, your presentation, how you receive, how you communicate. All of that is your health. And if we keep separating it, you are doing yourself a huge disservice. Right? It's almost like driving in the dark with like only the tiny lights instead of the normal lights.
Nice.
Yeah.
Sometimes, like, depending on what's going on in your life, you might need like the brights on for a little bit, and then you can turn them down and use the normal lights. Nice. And then eventually, when you ride it out, the sun comes up. So it's just about figuring out when to turn the lights on, when not, when your environment doesn't need as much support. And I firmly believe that. And I think even when I graduated PT school as a young whippersnapper 10 years ago, I think that I believe that. I just didn't understand how to communicate that. And then with that understanding, I was able to help usher my patients into even better healing.
Nice.
Right.
Nice. That's one of the reasons why I've often said to medical professionals, body workers, when you, and what you're kind of even saying, when you first graduate, you may have all this knowledge, but you don't know anything yet.
Right.
Right? You don't know. And I used to tell you, your first 100 clients or your first 100 patients don't count. They are practice. They are what you need to go through to then learn how to do this work. You can learn the pieces, and I often equate it to a driver's license. When you get a driver's license, it doesn't say you're a driver and you know how to drive. It basically is your pass to now go out on the road in the real world, in real life conditions, and now you can learn how to drive. And I think professional practice is exactly like that. Right? You get all of these pieces of information, you get all these tidbits, but you don't know how they go together until you are kind of banking that experience and putting it all together and seeing how it all fits.
Absolutely. I mean, you said it so well, because I think, especially when it comes to sex, I was also primed in that I grew up in a household that was very supportive of sexual health. So I didn't have that barrier, where that was fully supported. Like, if you tell your parents at the age of 15 that you want to help people with sexual dysfunction and pelvic floor dysfunction and stuff, most parents are going to be like, but both of my parents are like, cool, great, just as long as you're really good at it. All we care about with our children is excellence.
The work takes us places we didn't necessarily know we would go. So you're teaching. I'm very, very excited that you're teaching for us this weekend. Tomorrow, a day on biopsychosocial considerations with pelvic floor and sex therapy, but Sunday's half day on cultural considerations. So as you mentioned, that intersectionality, let's talk about how sexual health is more than ever, even more than 50 years ago, so entwined with social justice and how, as you said in your intro, how gender and ethnicity and the barriers to healthy sexual development.
Oh man, we need an hour. I'm going to start with this story because when I was in grad school, when I was in PT school, I didn't really fit in with the group. I was one of 2 Black students, and it's not that my parents put my sister and I in spaces where our whole lives, prep school from age 5 to 18. My sister went to Ivy League and then UT Law. Like, we're we can code switch like the best of them. But I think I was in a time in my life where I was thinking, well, it's more than just, manual therapy and this, like, there's more to health than this. And I went to this talk, in Chicago, this public health talk. And he was talking about, I can't remember his name, but he was a physician talking about the impact of racism on health and how the problem wasn't race, it was racism. It was the oppression that made people sicker. And I had never heard of it. I knew the disparities, but I didn't think about it in that way. And I'm like, you mean all this stress I lived through? There's a name. It gets acknowledged in research and in medicine. And I'm in a doctoral program, and this is the first time I was hearing this. And I was like, man. And so I went to my chair and I said, hey, I need more of that education. I want more of that. I'm going to do the PT thing, but I need more of that.
Nice.
So she said, she's Dr. Demetra John. So she was a physical therapist, and then she got her PhD in public health. So she decided, okay, yeah, I'm going to set you up in this Urban Allied Health Academy at the University of Chicago. So it was me and a bunch of kids from different backgrounds and different specialties. And we just learned about public health measures. And then I applied for the Albert Schweitzer Fellowship in Chicago. And I became an Albert Schweitzer Fellow, which was, for me, life-changing. Because my project was working with homeless LGBTQ youth in Chicago, designing health interventions for them. And so it's funny because as a PT student, you're thinking, why is she doing all of this?
Yeah.
But for me, that was how I was going to be a great therapist. That was how, because I needed to know this world. I needed to know all of the world. I needed to know the intersections.
Mm-hmm.
Because you know, I kept thinking like, oh, it's more than just like eating right, doing yoga, having more me time. How do we address these real social determinants of health, which is just kind of a classy way of saying oppressive structures?
Yeah.
How do we deal with these oppressive structures? How do stereotypes impact how people view themselves? And if we have stereotypes like the archetypes of Black women, right? The Jezebel, the angry Black woman, all of that. If you're trying to live your life in respectability politics and trying to avoid being perceived as a Jezebel or an angry Black woman, isn't that going to impact how you perceive sex? Isn't that going to impact how you engage in sex? Isn't that going to impact how you communicate problems with sex? And if you're working with someone who doesn't think about that or doesn't understand that that's a layer and that's a shame as an identity, and I'm just using a Black woman because you can do this with any person, but I chose Black woman because I'm a Black woman. You know, that I need my therapist to be woke about that.
Right.
I need them to be clued in. I need them to not be asleep on that.
Nice.
And I need them to not be fragile about it either. And that's hard.
And I find that that's a big part of where, I don't want to say we're stuck right now, but there's an element where we are stuck, because I think even with the sort of enlightenment movement that's kind of coming about, you know, we have organizations like SECUS, right, the Sexuality Information Education Council of the U.S., ASEC, the American Association of Sexuality Educators, Counselors, and Therapists, and all of these people in this field that are woking up to some degree, and we can talk easily about doing sexuality work, sexuality education, sex therapy, and I would include health treatments as well, through the lens of social and racial justice. And where I find myself stuck is that sounds really good on paper. But what does that look like? How do we actually do that? What does sex through a lens of social and racial justice actually look like?
To be honest with you, can I just tell, I've been thinking about this for the past 6 weeks. I think that there should be like a SAR for racism.
Yes, absolutely. And if I may say, I think this is the third time in the last as many weeks as I've heard that. I think we need to do that.
I think that is an entry point, because I think that, you know, for me, I'm Black all day, every day. I wouldn't choose, I would choose being Black every time if I had my choice. But I'm also weathered. You know, I've been in the skin for 35 plus years, and I'm not as fragile. I'm used to hearing this stuff, right? If James Baldwin, if you haven't watched I Am Not Your Negro, it's one of my favorite documentaries, but he makes this point where he says that Black people have studied white people their whole life because they have to. It's a form of survival.
Right, yeah.
But white people have not.
Never had to.
They've never had to. And that's where the fragility comes in. It's almost like you're in an incubator your whole life, and then someone just cracked the glass, and now it's like, ooh, like everything feels a little too much. I always tell people just to hang in there. You're gonna get bigger, you're gonna get tougher. You're gonna start to see that when someone says something, it's not about you personally, but you being all fragile kind of perpetuates the oppression. And so I feel like that, I think people really, it's not sexy, it's not the best answer, but people really need to work on their own self before they can do anything to help anybody else. They need to work on their own identity of whiteness, and how do they perpetuate the concept of white supremacy. And when I say white supremacy, it's not just about Black and white people, it's white supremacy, period. And how that engages with anyone that is not white. And also for people of color and Black people, that stuff gets internalized too. And they need to work on that.
Yeah.
Because sometimes they can be even harsher to each other in that they've internalized that racism so much. I just did this anti-racism course, and I said that it has to be in the interactions that you have with your colleagues at work. It has to be like, how do you use your power? You have to stand in front of the police. You have to stand between your colleague and the police, which is like administration or other people at work. You have to speak up.
Mm-hmm.
You have to say no. Like, why are you calling her aggressive when she disagreed with you? You didn't call so-and-so aggressive.
Wow. Yeah.
Like, it's those little things.
Mm-hmm.
Right? If you're an educator, right? If you're on faculty and you're seeing the 3 black students sitting in the corner together, don't try and separate them or ask them why they're not mingling with the other kids or the other students.
Well,
Don't disrupt that community that they have. Don't let them be afraid to sit together.
Right.
Because their whole life is meant to make white people comfortable. If they want to sit with each other to try and gas each other up because it's tiring, leave them alone.
And I think is such a big piece to all of this kind of stuff, and I think that's part of what underlies all this privilege that white people have. And it really is, I think, the ultimate base of that privilege is just to be comfortable and to have everybody cater to that white comfort.
Absolutely. Absolutely.
So white people need to be a little uncomfortable.
Absolutely. And I think the specifics, like I say, giving people specifics about how do you react when a black colleague or student or friend gets angry versus how you react when a white colleague, student, or friend gets angry or patient.
Mm-hmm.
Do you feel more or less threatened?
Mm-hmm. Mm-hmm.
And being honest with yourself, if you say, yes, I feel more threatened, well, okay, fine, great. And then where does that come from?
Right. Let's look at that.
And unpack that.
Mm-hmm.
But that's hard stuff, because everyone assumes that like they're being racist is like evil, and it's like everyone says racist stuff. That's just part of their culture. We need to kind of either make that word less evil, even though it's not great to be racist, so that people can understand that they can participate in that, even with their silence. Is important.
Right. But see, that even speaks to what the point we just made. If we're going to look at how do we soften the word racist, it's just another example of how do we help white people be more comfortable in all of this.
I know, but listen, as I talk, I have to tell you, and this is the thing that's crazy, even as I'm talking to you both, I'm thinking deep down, am I being too strong for your audience?
I get it. Yeah.
I can't help it. I'm always in the mode of like, I have to protect myself. Right? I can't be perceived as too anything, because I have to protect my livelihood. And I think that's when they talk about ancestral pain and things like that like if you were talking about Jim Crow era, people were like, there were laws, like I can't be too animated with white people, or else my family will suffer, or I will die, or I will lose my job, or my home will burn down.
Right.
And then nowadays, it's in the flavor of, I don't want to lose my professional reputation. I don't want it to be painted by being an angry black female, because no one wants to work with an angry black female.
Mm-hmm. Yeah, and that's a piece that really has to be acknowledged more and spoken of more. We're at a point where we can kind of acknowledge, and I've said this a number of times before, that one big difference, and I look at this as privilege, that if I'm driving in my car and I see a cop in my rear view mirror, I'm worried about getting a ticket. But if a person of color is driving along and they see a cop in their rear view mirror, they're worried about getting shot. And what nobody talks about is all of that stress and anxiety and everything, the thought process of going through, I got to make sure my hands are on the steering wheel before they get up here, got to have my wallet out, I got to make it clear I have to do that. There's all of this deliberation that people of color have to constantly, almost every minute of every day, go through. And you're describing something that's more occupational that I've never heard anybody really talk about before, always having to be constantly evaluating and vigilant about how you're being received by your colleagues. That other people don't have to do that.
Because
men in particular don't have to do that.
Well,
white men.
Well, maybe they should a little bit more, but that's...
Look, that's why the health of women, Black women with terminal degrees or graduate degrees, their health is almost worse than that of like a white woman in high school because of the stress, because as the higher you go, the fewer of us there are, which means we're on our own 24/7. And you have to watch your back, you know, and you can't really trust. And it's not that we're paranoid. And the thing is, if I had to think about this every day consciously, I would literally lose my mind, you know. But my sister and I used to, you know, joke about, and like I think a lot of Black people joke, where we talk about our corporate work job being the plantation, you know, where it's like, man, like, you know, they were super super extra today. And sometimes the examples of behavior and racist behavior in professionalism, which is hugely based on white standards of behavior, by the way.
Well, if anybody can't tell by now why we were so excited to have UC join us this evening, then you're just not paying attention. This lady's dynamic and dynamite, and really just
Thank you.
I'm honored to know you, even more honored to have you teaching our students at Modern Sex Therapy Institutes this weekend. I know for all of our therapists and medical professionals who are listening, it's awful last minute and springing on you, but it will be recorded and available later. Uchenna Ossai will be teaching, as I said, tomorrow, a day on biopsychosocial considerations in pelvic floor and sex therapy, and Sunday, cultural considerations. I'd say probably the more important of the two, as we've been discussing. Thank you, dear, so much.
What
really,
a pleasure to meet you.
I'm looking forward to a long and fruitful affiliation.
Thank you.
And,
I'm really excited.
We'll talk over the weekend, and thanks for speaking for our audience on Sex Talk.
Indeed. Thank you so much.
Thank you.
You know, I'm so glad to have had the opportunity to have met her. I hate to use the word again, it's overused, but feel privileged to have been able to talk to her and really see that somebody like that is out there. And it's so gratifying.
Yeah,
it really is.
I told you, kudos to my brilliant business partner, Rachel Needle, found UC, and she taught for us during the weekend we did in Houston. I can't believe it's 2018 already. And she just knocked me out. I knew she was someone that we had to get to know more. And
yeah, I'm so glad you did, because and again, hopefully you really caught that as well in what she had to offer. And such a unicorn. It truly is. I don't want to keep using that term, but it's so rare to find somebody who, number one, is willing to go so far out of her way and really out of her field to be so well-rounded and sexually literate, and just see all of these different necessary avenues to bring together just so that she can help people.
yeah, but I like that part of the conversation where we talked about where the work takes us when we're not expecting it to. That's really, that's the wonderful journey of being a sexologist.
It really is. So it kind of makes me feel a little bit more comfortable, if I can use that word, with the fact that most medical schools, these professional programs don't offer anything really in the way of sex and sexuality.
Nor do our mental health, social work, counseling, marriage
they really
and family therapy. How many times we rave about that one? Because it's right in their name.
Exactly.
You're a marriage and family therapist, and don't think about why people get married and how they have families.
Right. And just how they interact with each other.
The plumber that doesn't do toilets.
Exactly.
Nobody would tolerate that, but yet we tolerate marriage counselors that don't talk about sex.
Right. So those people like UC and people that are in that field, that are coming from these different areas, that they go so far out of their way. And I'm still framing it that way because I just, give her that credit. But you're right, where that work takes her, to be willing to get the training, to get the education, to develop those skills.
And one more plug before we wrap. Again, for all of our sexologists out there, educators, therapists, and medical clinicians, if you want to hear more of UC's brilliance, she will be teaching for us this weekend, and the lectures will be recorded and available. So It's okay if you can't attend tomorrow or Sunday. You can watch anytime in the privacy of your own home or office. Go to modernsextherapyinstitutes.com.
And you know what? Try to make it this weekend, because it's not like you have to book travel plans or anything like that. It's all done virtually. So you can just register, sign on, and there you are.
Live is better.
Mm-hmm.
Right. So thanks again to UC. We adore you. And thank
Truly.
you all for watching another episode of Sex Talk with the Siegel Brothers. We'll be back next Friday and every Friday at 7 p.m. on East Coast time.
Indeed. Stay well.
Thanks for watching Sex Talk with the Siegel Brothers. Join us each week on Friday at 7 p.m. Eastern. You can also follow us on Facebook and subscribe to our YouTube channel to stay on top of the latest developments in the ever-changing world of sex and sexuality.